Welcome back to the last talk. The speaker is Dr. Shambavi Richard. Dr. Shambavi Richard is an associate professor of medicine in hematology and medical oncology at the Icahn School of Medicine at Mount Sinai. So she has been practicing for more than 15 years and has extensive experience in transplantation for multiple myeloma. She's also the coordinator of CAR-T and stem cell therapies for multiple myeloma in Mount Sinai. The unit is the largest myeloma program in New York City and one of the largest in the States. She played a very active role in the approval of several drugs that are now FDA approved for the treatment of multiple myeloma. Her talk today will be targeting the XPO1 in relapsed refractory multiple myeloma. Thank you.
I want to thank the organizers for inviting me to speak at the Hong Kong Society of Myeloma. It's a great pleasure. I'm Shambavi Richard from Mount Sinai, New York, and in the next half hour or so, I will give a brief overview of the role of XPO1 inhibitors in multiple myeloma. These are my disclosures. I'll start my talk by briefly going over the mechanism of action of XPO1 inhibitors, focusing on selinexor. The hallmarks of cancer include self-sufficiency in growth signals, insensitivity to anti-growth signals, evasion of apoptosis, sustained angiogenesis, and limitless replicative potential. XPO1 is a nuclear export protein that is central to these hallmark processes. So this is the major nuclear export protein for tumor suppressor proteins, such as p53, oncoprotein mRNAs, such as c-Myc and cyclins, and glucocorticoid receptor. The high XPO1 levels enable cancer cells to escape tumor suppressor protein-mediated cell cycle arrest and apoptosis. Selinexor has a novel mechanism of action, and it is an XPO1 inhibitor. This is the structural formula of selinexor. XPO1 inhibition by selinexor targets these hallmarks of cancer by reactivating the multiple tumor suppressor proteins by preventing nuclear export, as shown in the picture on the right. It inhibits oncoprotein translation by sequestering the mRNA in the nucleus and reactivates glucocorticoid receptor signaling in presence of dexamethasone. Multiple myeloma, XPO1 is overexpressed in myeloma cells more than in normal plasma cells, MGUS or smoldering myeloma, as seen in the picture below. It is correlated with shorter survival, as you can see in the graphs on the left, for both the event-free and overall survival. And this is from a paper in leukemia by Tai et al. The blue lines on the graph are low expressors of XPO1, and the red lines are the high expressors. XPO1 levels also correlates with increased lytic bone disease, and selinexor has demonstrated synergistic activity in combination with bortezomib in preclinical studies. Preclinical basis for the STORM trial. STORM was an important study. It was published in the New England Journal of Medicine by Ajay Chari from our institution and was instrumental in the FDA approval of selinexor in relapsed refractory myeloma patients. Acronym for selinexor treatment of refractory myeloma. This was a pivotal phase 2b multicenter trial. 122 patients were enrolled in the intent to treat population. Patients had to have disease refractory to at least one IMiD, one proteasome inhibitor, daratumumab, and steroids, and be refractory to the last or the most recent regimen. The majority were penta-exposed or triple-class refractory. Creatinine clearance could be as low as 20 ml per minute. So this was a very advanced group of patients, as one might encounter in the real world after having been exposed to multiple drugs and regimens. Selinexor was given at a dose of 80 milligrams twice a week, along with dexamethasone at 20 milligrams twice a week on days 1 and 3 weekly. So a total dose for selinexor of 160 milligrams weekly was given. And this was given in 4-week cycles. The treatment was given until progression of disease, death, or discontinuation. All had progressive disease at the time of enrollment, typically rapidly progressive disease. The primary endpoint was overall response rate, and secondary endpoints included duration of response, clinical benefit rate, progression-free survival, and overall survival. All responses were assessed by an independent review committee. Statistics are shown on the table. Median age was 65. Time from diagnosis was a median of 6.6 years, and median lines of therapy was 7, a range of 3 to 18. 53% of patients had high risk cytogenetic abnormalities. Patients were frequently rapidly progressing at the time of enrollment on the trial. The median percent change in myeloma markers between screening to cycle 1, day 1, which was a median of about 12 days, was 22%. All patients were refractory to at least one PI, one AMED, and an anti-CD38 antibody. 96% were refractory to the most potent agent in a class. 68% were penta-refractory. 84% had had a prior stem cell transplant, and 2% had had a prior CAR T. It shows the responses from part 2 of the STORM trial. In the overall intent to treat population, the overall response rate was 26.2%, and the clinical benefit rate was 39.3%. VGPR or better was seen in 7% of patients, and 20% had a partial response. On the last bar graph on the right, you can see 83 of the 122 patients were penta-refractory, and the results for this group, the overall population, with an overall response rate of 25% and clinical benefit rate of 37%. VGPR or better was 6%. The median time to response was 4.1 weeks. The median duration of response was 4.4 months. 39% of patients had stable disease. Response rates were consistent regardless of when patients were treated with daratumumab, whether it was in the last line or prior to that. Survival for the overall group was 3.7 months, as seen in the graph on the left. The graph on the right shows the progression-free survival curves for the various response categories. The deeper the response, the longer the progression-free survival. As you can see, patients who were in partial response or better had a median progression-free survival of 5.3 months, and patients who had a clinical benefit, so a minimal response or better, had a median progression-free survival of 4.6 months. However, patients who had stable disease did much less well, with a median PFS of 2.2 months. Overall survival showed a similar pattern. So median overall survival was 8.6 months for the overall population. But surprisingly, patients who had at least a PR had a similar overall survival as patients who had only a minimal response, with a median overall survival of 15.6 months, compared with a median overall survival of only 1.7 months in patients who progressed or were not evaluable, with a highly significant p-value of less than 0.0001. Patients who had a stable disease also did less well than the overall group, with a median overall survival of 5.9 months. Here are the safety data from STORM. The most common adverse events that emerged during treatment were thrombocytopenia in 73% of patients, fatigue in 73%, nausea in 72%, and anemia in 67%. The most common grade 3 or 4 adverse events were thrombocytopenia in 58% of patients, anemia in 44%, fatigue in 25%, hyponatremia in 22%, and neutropenia in 21%. 96% of patients discontinued treatment, mostly due to progression of disease or adverse events. 18% discontinued due to treatment emergent adverse events. Dose modifications and interruptions had to be done in 80% of patients, and the majority of these were in the first couple of cycles. Common reason for dose interruption was thrombocytopenia, as in 43% of patients. Thrombocytopenia occurred more frequently in patients who had thrombocytopenia at baseline than in those who did not. 6 patients with grade 3 or higher thrombocytopenia also had grade 3 or higher bleeding. The median duration of treatment was 9 weeks. Side effects were reversible, and there was no major organ toxicity. So these data resulted in FDA approval of selinexor plus dexamethasone in patients with penta-refractory multiple myeloma, refractory to 4 or more therapies, including two or more PIs, two or more IMiDs, and an anti-CD38 monoclonal antibody. As is the norm with new drug approval in myeloma, selinexor was then tested in earlier lines of treatment in combination with the standard of care backbone, and in this case, that backbone was bortezomib and dexamethasone. The registrational Boston study was the next major study in the development of selinexor. Global open-label randomized controlled trial in patients with myeloma who had received 1 to 3 prior therapies. 402 patients were randomized 1-to-1 to XVD in 5-week cycles of selinexor 100 milligrams weekly, bortezomib 1.3 milligram per meter squared weekly, and dexamethasone 40 milligrams weekly. The control arm was VD in the standard Q3-week schedule, with twice a week bortezomib and dexamethasone given 4 times a week. After 8 cycles, VD was switched to 35-day cycles in the same schedule as arm A, so weekly bortezomib. If at any point patients had progression of disease on VD as determined by an independent review committee, or they had intolerable toxicity, they could cross over to the XVD arm. Therefore, 40% lower bortezomib and 25% lower dexamethasone dose at 24 weeks was planned. That's around 8 cycles in the XVD arm versus VD arm, which would entail 37% fewer clinic visits over the first 6 months of treatment. Patients were stratified by prior PI therapies if they received it or not, number of prior anti-myeloma regimens, 1 versus more than 1, and RISS stage at study entry at stage 3 versus stage 1 and 2. The primary endpoint was progression-free survival. Secondary endpoints were overall response rate, VGPR or better, or grade 2 or higher peripheral neuropathy. Other secondary endpoints included overall survival, duration of response, time to next treatment, and safety. Inclusion and exclusion criteria were pretty similar as for the STORM trial. I've highlighted some important things in red. They had to have progressive measurable myeloma by the IMWG criteria. They had to have had 1 to 3 prior anti-myeloma regimens. If they had received a prior PI, they had to have had at least a PR and had to be at least 6 months since the last PI. Creatinine clearance, again, was pretty generous. Was pretty generous. They had to be at least 20 ml per minute. ECOG status score had to be 0 to 2. They had to have adequate organ function, hepatic and hematopoietic, ANC more than 1,000, and platelets over 75,000. A couple of key exclusion criteria were over grade 2 neuropathy or grade 2 or higher neuropathy with pain at baseline, or a prior intolerance or grade 3 or higher toxicity to bortezomib were excluded. Also, patients with active plasma cell leukemia or myeloma involving the CNS were not eligible to be enrolled on this clinical trial. Characteristics were well balanced between the treatment arms. The median age was 66 for XVD and 67 years for VD. Median time since diagnosis was 3.8 years and 3.6 years, respectively. High-risk cytogenetic abnormalities were seen in 50% and 46%, respectively, of patients. The majority of patients, as you see, were RISS 1 or 2, and the majority had had 1 or 2 lines of therapy. In terms of prior PI exposure, about 70% had prior bortezomib and 10% had prior carfilzomib. Primary endpoint was met at a median follow-up of 13.2 months for XVD and 16.5 months for the VD arm. The median progression-free survival was significantly longer for XVD at 13.93 months versus 9.46 months for VD, representing an increase of about 4.47 months in the median PFS. Hazard ratio was 0.7, so there was a 30% reduction in the risk of disease progression or death. The study led to the FDA approval of selinexor as a treatment option for multiple myeloma following 1 prior therapy in December of 2020. Analyses were done by several groups as shown on this slide, and consistent trends to PFS benefit was seen for XVD as compared to VD. The bar graphs show the median PFS in months in blue for the XVD groups and in pink for the VD arm for various subgroups, including len refractory, DARA exposed, high-risk cytogenetic abnormalities, prior PI exposure, prior lines of therapy, creatinine clearance, and age. The citations are as shown in the bottom of the slide. Of course, there are limitations to subgroup analyses. These subgroup analyses were exploratory in nature. They were not included in the study objectives, so they were not powered or adjusted for multiplicity to assess the progression-free survival across these pre-specified subgroups. Overall survival was a secondary endpoint. Survival data was immature as of this data cutoff, and there were 148 deaths, so that's about 36.8% of the overall group. 68 in the XVD arm and 80 in the VD arm had died. There was no difference really of the median overall survival. It was close to about 37 months and 33 months respectively. Of interest, 30% of patients from the VD arm had crossed over to XVD arm, so that may explain some of this. Endpoints included VGPR or better, duration of response, and time to next treatment. From this table, you can see the overall response rate was 76.4% for XVD versus 62.3% for VD for an odds ratio of 1.96. VGPR or better was 44.6% versus 32.4%, odds ratio was 1.66. The median duration of response was 20.3 months for XVD versus 12.9 months. Hazard ratio was 0.81. And time to next treatment was 16.1 months for XVD and 10.8 months for VD. Hazard ratio was 0.66. Time to response was again short at about 1 month for the XVD arm. Safety data for Boston, adverse events were more common in the XVD arm. The most common hematological adverse events was thrombocytopenia, 60% all grade and 39% grade 3 or higher, of whom 2% had grade 3 or higher bleeding as well in the XVD arm. 16% had grade 3 or higher anemia, and neutropenia was even less common at 9%. All of these parameters were even less common in the VD arm. In terms of non-hematological toxicity, adverse events were again more common in XVD across the board, except for peripheral neuropathy. But the majority of AEs were grade 1 or 2. The common ones, as listed here, include nausea, fatigue, anorexia, diarrhea, pneumonia, weight loss, asthenia, and cataracts. Interestingly, new onset cataracts was seen in XVD in 24% versus 8.5% in VD, and worsening of cataracts occurred in 20.5% of patients in XVD versus 7.9% in VD. And this is felt to be a class effect of selinexor. Was the only adverse event that was more common with VD at 47% versus 32% for SVD. Grade 3/4 peripheral neuropathy also was higher in VD at 9% versus 5% for XVD. Dose modifications were required for 89% of patients with XVD and 76% for VD. 21% and 16% in XVD versus VD arms discontinued treatment due to treatment emergent adverse events. The median time to treatment discontinuation was 194 days in XVD and 184 days in VD. Post hoc analysis of the Boston study to determine the efficacy and safety among patients with high-risk cytogenetic abnormalities. We defined high-risk cytogenetic abnormalities as patients who had at least one of these abnormalities: deletion 17p, translocation 414, a translocation 1416, amplification of 1q21 in 10% or more of screened plasma cells, with the amplification 1q21 requiring at least 4 copies. Fluorescent in situ hybridization, FISH, was performed centrally on CD138 positive cells isolated from the bone marrow aspirates collected at screening. By this definition, 70 patients had high-risk cytogenetic abnormalities in the XVD arm and 71 in the VD arm, which composed about 36% and 34% of patients, and there is the breakdown of the frequencies of the various cytogenetic abnormalities we've seen. graph on the top left shows significantly improved progression-free survival for XVD relative to VD in the standard risk group, 16.6 months for XVD versus 9.5 months for VD. This had a significant p-value of 0.004. In the high-risk group, in the bottom left, the progression-free survival was 12.9 months for XVD versus 8.6 months for VD. And you can see the hazard ratio was 0.73. P was 0.08. The graph on the right top shows the same analysis of progression-free survival for patients with one cytogenetic abnormality. And this shows a median progression-free survival of 10.2 months for XVD versus 8.6 months for VD, and the hazard ratio was 0.69, p-value was 0.08. Shows again the PFS for patients with two or more cytogenetic abnormalities. And here you see the PFS for XVD was 15.5 months versus 5.9 months for VD. Hazard ratio was 0.54, but P was 0.09. Now, although most of these did not reach statistical significance, the numbers were small, and there's a clear trend for improved PFS with XVD for these high-risk groups. And I apologize, we separated out the individual cytogenetic abnormalities and analyzed the progression-free survival, the overall survival response rates, duration of response, and the time to next treatment for each one. And I want to highlight just the deletion 17p data as outlined in the pink box. Although numbers were small, there was a total of 37 patients with deletion 17p, 21 in the XVD arm and 16 in the VD arm. The median progression-free survival, as you see, was 12.2 months for XVD and 5.9 months for VD, and the hazard ratio was 0.38. P-value was highly significant at 0.008. This was intriguing in light of the selinexor mechanism of action as an inhibitor of cytoplasmic export of the tumor suppressor protein such as p53, which is located on the short arm of chromosome 17. But larger data sets will be required to see if this idea bears out. To the STOMP trial. STOMP is an acronym for selinexor and backbone treatments of multiple myeloma patients. Ongoing multicenter open label phase 1b/2 study to assess the efficacy and safety of 10 combination therapies in 11 arms, both in dose evaluation and expansion phases. 10 arms enroll patients with relapsed refractory myeloma, and one arm is for newly diagnosed myeloma. The plan was to enroll approximately 518 patients, and these are the various combinations and dose ranges as shown on the slide. The combinations being studied include selinexor bortezomib dex, selinexor dara dex, selinexor carfilzomib dex, selinexor pomalidomide dex, selinexor revlimid dex, selinexor with pomalidomide, Velcade, and dex, with Ninlaro and dex, with elotuzumab, pom dex, with belantamab and dex, with dara, pom dex, and finally selinexor with revlimid and dex in newly diagnosed patients. You can see the RP2Ds for the first 5 where these have been determined. Others are being tested in various dose ranges to find the RP2D. Slide goes through some of the arms that now have efficacy data as reported in abstract forms in various meetings or publications. The first column in XVD was reported by Baylis et al. On 42 patients. RP2D was determined to be as per the Boston regimen. Selinexor carfilzomib dex was reported by Gasparito on 32 patients, and RP2D was determined to be 80 milligrams of selinexor weekly with carfilzomib dose 56 milligram per meter squared weekly and dex of 40 milligrams weekly. Selinexor dara dex was reported also by Gasparito on 34 patients, and RP2D was determined to be 100 milligrams of selinexor weekly with standard dose and schedule of dara and 40 milligrams of dex weekly. In the Seli-Pom-Dex group, reported by White et al. At 39 patients on that arm, and the RP2D was 60 milligrams of weekly selinexor, 4 milligrams of pomalidomide for 21 days out of 28, and 40 milligrams of dex weekly. Selinexor revlimid dex was reported by White et al. relapsed refractory as well as newly diagnosed patients, RP2D was again same dose of Seli at 60 milligrams weekly and Dex, and the Revlimid dose was 25 milligrams in 21 out of 28 days. Patients with relapsed refractory myeloma, as you can see, they had a median of 2 to 4 prior lines of therapy. The results are generally consistent as seen from this slide, with median PFS ranging from 9 to 15 months in those that have been reported out. Overall response rate ranges from 60 to 78%, VGPR or better from 30 to 43%, and clinical benefit rate was 70 to 81% overall. Patients who were refractory to the backbone in the regimen predictably had a much lower response rate than those who were exposed to that drug but were sensitive or naive. And you can see that in the last row on the table. XRD in newly diagnosed patients was reported on 7 patients thus far and had a 100% response rate and VGPR of 70% as shown in the last column. Most common adverse events were anorexia, nausea, fatigue, mainly grades 1 and 2, and thrombocytopenia, grades 3 and 4 were seen. 7 patients relapsed after CAR T and were treated with the selinexor combinations as shown on this slide. These were heavily pretreated patients. Best response and duration of response to CAR T are shown on the row above. 1 patient was treated with Seli-Dex on the STORM trial, 1 was treated with XVD, and the rest were treated with Seli-Carfilzomib-Dex. The waterfall plot shows the responses and duration of response on selinexor-based treatment. There was 1 stringent CR, 3 VGPRs, 2 partial responses, and 1 minimal response as best response seen for this, and for a median duration of selinexor treatment of 6 months, showing that selinexor combinations are effective in relapses even after CAR T. Here's now to supportive care for patients on selinexor. Selinexor can be a challenge to administer without optimal supportive care. These are some of the supportive care strategies that we use at Mount Sinai to be able to optimally administer the drug. Many of the side effects are seen primarily in the first few cycles. Patients then settle down and are able to tolerate it much better after that. A good antiemetic protocol is very important. Nausea for the first cycle or 2 can be very troublesome if we don't take preventive measures. On Dansitron, 8 milligrams POQ 8 hours for the first 4 days, starting with the selinexor day. Rolapitant, 180 milligrams day 1 and day 15, and olanzapine, 2.5 to 5 milligrams POQHS, as one of our standard cocktails that we use. Before starting treatment with selinexor, we provide at least the first 2 prophylactic antiemetics. Most patients end up needing a combination of all 3 above antiemetics. Aprepitant is avoided in general as it may potentiate the activity with dexamethasone and lead to hyperglycemia. But if you need to use it, then the dose is 125 milligrams PO/QAM on the day 1 and 80 milligrams for 2 days after that each week. We reassess need after cycle 1. 1 or both antiemetics may be tapered after about 6 to 8 weeks, depending on how the patient is doing. Appetite stimulants may be helpful. We do avoid megestrol, however, because it can increase propensity to develop blood clots. We can use loperamide for diarrhea. It's very useful. And a nutrition consultation is very useful as well. They can teach patients to maintain a caloric intake with high caloric snacks, maintain their daily weights, and keep a food log to keep track of their nutrition. So these recommended supportive care measures can reduce the risk of severity of certain toxicities. In terms of fluids and sodium, dehydration and hyponatremia can occur. We maintain hydration with 2 liters daily water and salt-containing drinks, such as sports drinks, as needed to minimize the risk of hyponatremia. We do get weekly chemistries panels on the blood work. IV fluids are given as needed with normal saline, and depending on the level of hyponatremia, sodium chloride tabs at 1 gram TID we use as well. Fatigue is a common side effect. We do check for underlying causes, especially dehydration or anemia, but if related to selinexor, stimulants such as methylphenidate at 5 to 10 milligrams daily as needed has been pretty effective. In terms of cytopenias, platelets 50,000 or less, we start romiplastin at 10 microgram per kilogram weekly. Dose reductions and drug holidays may be very helpful in keeping patients on the selinexor regimens. I'll talk more about the thrombocytopenia mechanism of selinexor, which is unique, and its unique management strategy in a minute. An expert consensus from an IMF roundtable, some things that are important is that it's important to educate patients early and set expectations that side effects will significantly improve with subsequent cycles. Many patients, as I said, may not have too much nausea beyond cycle 2. Early intervention really helps to mitigate toxicities to allow delivery of the drug over a longer period in order to obtain the most benefit. But also it helps to educate the patients and alleviating patient anxiety and letting them know that even lower doses have shown to be efficacious. So persistent adverse events can be managed with several mechanisms like the dose reductions and using supportive care. The log for the patient for at least the first cycle is really been helpful because it makes the patient aware and makes us cognizant of the caloric intake and how the patient is handling the drug. We tend to back on day 3 or 4 of the first week of treatment to assess for adverse events and provide IV hydration as needed. So we jump in ahead of it rather than wait for the full 1 week for the first week. Increasing patient awareness to check the daily weight and intervene with education and high caloric snacks do really help. Thrombocytopenia from selinexor is unique and interesting. Kinetics of thrombocytopenia typically occurs 2 to 3 weeks after starting and will recover with a 1 to 2 week dose delay and or modification. The XPO1 blockade causes thrombocytopenia by inhibiting thrombopoietin signaling and blocking the differentiation of stem cells into megakaryocytes via the c-MAPL STAT3 pathway. And this is depicted on the figure on the left. Selinexor-induced thrombocytopenia is reversible when TPO agonists are administered in the absence of selinexor. And this was shown elegantly from a paper published by Mackless et al. In Blood. Thrombopoietin is the major determinant of megakaryocyte differentiation and maturation from the hematopoietic stem cells. So in this experiment, and you see on the, referring to the picture on the extreme right, TPO knockout mice were treated with a control with selinexor alone, with TPO alone, or selinexor and TPO, and platelet counts were measured. You can see that if you give the TPO mimetics by themselves to these TPO knockout mice, they actually have a nice bounce in their platelet count. But if you administer the selinexor simultaneously with the TPO mimetic, there's no response, suggesting that selinexor is actively inhibiting the TPO signaling in vivo. And again, also, if you give the selinexor alone, it didn't really impact, it didn't reduce the platelet count, revealing that, in fact, its inhibitory effect is mediated exclusively through that TPO signaling mechanism. So selinexor by itself does not have a cytotoxic effect on the platelets or the megakaryocytes. On the graph in the middle is a sample of a patient treated with selinexor. The thrombocytopenia, as you see, sets in around week 3. You start the romiplasm simultaneously and there's no response. But when it's given during the drug holiday, there's a nice spike in the platelet response showing that TPO is unable to overcome selinexor blockade when they're administered simultaneously. Formative in how we handle the thrombocytopenia. This was shown by Ajay Chari et al. That if the patient has a lower baseline platelet count, they have a higher risk of developing grade 3 for thrombocytopenia. So you can see from this graph that patients who started off with a baseline platelet count of less than 75,000, almost 100% of them developed grade 3 for thrombocytopenia. I'll present a case of a patient illustrating the use of selinexor in early relapse. This patient received selinexor Velcade Dex at first relapse on the Boston trial. So this is a 50-year-old male who was diagnosed with IgG kappa multiple myeloma in January of 2013. He had ISS stage 1 disease and FISH was normal at diagnosis. He started in January 2013 with Velcade Dex for 1 cycle and then Velcade Revlimid and Dex for 3 cycles. and then underwent an autologous stem cell transplant on the BMT-CTN 0702 trial with VRD consolidation and Len 15 milligrams maintenance until December of 2015. At that point, he elected to go off therapy to improve his quality of life. He progressed, unfortunately, in March of 2018 and was then enrolled on the KPT Boston trial and randomized to the XVD arm. Cycle 1, day 1 was in April of 2018. He underwent progressive dose reductions of selinexor, initially to 80 and then to 60 milligrams in the first few months of therapy. And this was primarily due to a grade 2 weight loss, which resolved with the dose reduction and the antiemetics. He did attain a stringent CR. His other complication was that he did have cataracts, and for which he underwent surgery. After 36 cycles, as per protocol, he went off study, but continued on standard of care selinexor, dexamethasone, and Ninlaro instead of Velcade, really for convenience, and did very well for a while, and has now started to show a slight increase in his M spike from 0 to 0.2 since December of 2021. So biochemical evidence of relapsing disease, but not actually not a progression of disease yet by IMWG criteria. And the PET-CT continues to remain negative. I have shown this in this graph, just as M spike at diagnosis, at relapse, and now with that slight bump up to 0.2, but otherwise still stable, PET-CT negative, and continues to receive the same regimen. I'll stop here and want to acknowledge the patients and caregivers without whom these studies could not be done, and my colleagues and staff at the Multiple Myeloma Program at Mount Sinai. Thank you for your attention.
Thank you, Dr. Richard. The presentation was pre-recorded, but now we have Dr. Richard joining us because Hong Kong is exactly 12 hours ahead of New York. So thank you very much, Dr. Richard, for joining us, 7 a.m. in the morning, New York time. So any questions from the floor? Dr. Richard, may I ask the first question? Since we are treating this kind of patients are usually very heavily treated. There are many of them penta-refractory, many of them very frail. I realized that most of the patients can tolerate from the STORM study about 80 milligram of selinexor. So in real practice, do you start with 100 milligram and then if the patient can tolerate, you lower the dose, or you advise us to give a lower dose like 80 milligram or even 60 milligram to start with?
I found that practically speaking, I find that 100 milligrams is a little tough for most patients to tolerate without having a lot of side effects. Now, the STORM study, they used the selinexor twice a week. It makes a big difference that we have moved towards the weekly dosing a lot. So I rarely use selinexor as a doublet. Most of the time, I use it the way we use it in Boston with Velcade, or if somebody has been exposed quite recently to Velcade, then I may use carfilzomib or one of the other combinations. So I tend to start at a slightly lower dose. I tend to start at 80. I rarely have, pushed it to 100. Sometimes I've had to dose reduce to 60, depending on the combination. With an IMiD, for instance, I don't go to the 80. I start with the 60. But with the weekly dosing, they actually tolerate it pretty well, even the elderly patients. And again, just as I said in the supportive care, I just start, I jump in ahead of the game with 2 antiemetics. I don't start with one. I automatically put them both on the, the anti-HD3 as well as the NK1 antagonist to start with. The olanzapine, I may add if somebody has continued nausea in spite of it, or if they have anorexia, it's really very helpful to add that third drug. So by being a little bit preemptive with this, I find that they actually handle it quite well.
Thank you. And you have another slide about the thrombocytopenia, about administration of TPO receptor agonists. So may I know the exact dosage that you give to the patient?
So I use the romiplastim at 10 microgram per kilogram. I found that when I tried to use the lower doses, I tried to escalate the way the original package insert for the for the romiplastim suggests. It takes longer to catch up, and then it's not quite as effective in the lower doses because this mechanism is really unique. It's really based on the thrombopoietin agonist to antagonize that thrombopoietin pathway. And so I just jump in straight with the 10 mics per kilo. I don't do it on the same day as the selinexor because, again, as the slide shows, when they're given co-administered, the same day, they have less of an effect. So I split it up by at least 48 to 72 hours if during the week. So midweek I may give the thrombopoietin receptor, and it's pretty effective. It keeps the platelet count at a safe level.
Thank you.
And I started as soon as the platelets drop to less than 50. I just start, and then it's effective almost like within a week or two.
Thank you. So any more questions from the floor? If not, thank you very much, Dr. Richard, for an excellent talk. Thank you.
Thank you.